factors to consider when treating, and a few mentions about the outcomes for rheumatoid arthritis. So karibuni sana. The first speaker then will be Dr. Etau. Dr. Etau is a consultant physician and rheumatologist at the Kenyatta National Hospital. He will take us through the first few sub-points of today's topic: when to suspect rheumatoid arthritis, the mimics and the complications of rheumatoid arthritis, and then factors to consider when planning treatment. So karibu daktari.
Thank you very much, Dr. Nagita. And welcome all to webinar today on rheumatoid arthritis. My name is Dr. Itao. I'm very grateful to the KNH Research Department for the unit for rheumatology to talk to all of us today. Rheumatoid arthritis, an overview. The objectives, as Dr. mentioned, is to go through when to suspect rheumatoid arthritis, what are the meanings, what are the complications, factors to consider in treatment planning. Dr. will continue on the long-term picture. When do we suspect a patient's rheumatoid arthritis? So I'll go back and use this just and say that rheumatoid arthritis is the commonest inflammatory polyarthritis with a prevalence of about 1 to 2% in most series. The same actually applies here. Rheumatoid arthritis is common in females, male to female ratio. So it's the other way around, female to male ratio of 3 to 1. It's common between the ages of 20 to 40 years and also between 60 to 80, usually a peak. But some people will just say it's common between the ages of 20 to 75 and becomes rare after the age. And risk factors which are modifiable, which includes smoking. And smoking remains a great modifiable risk factor for rheumatoid arthritis. Twofold increased risk is a family history, and there's a fourfold risk in monosclerotic disease. So family history of rheumatoid arthritis is one of those key things that one takes, and then that increases the likelihood that one has rheumatoid arthritis. Though patients with rheumatoid arthritis may not have necessarily have a family history. The strong genetic risk for rheumatoid arthritis is often B1 gene, but other than MHC, include the PAD4, PTPN, 22, they are polyprotein. There are infectious risk factors which include virus, B19, important cause of gingivitis, Porphyromonas gingivalis, and this is key and what gives a relationship between gingivitis and rheumatoid arthritis. And dysbiosis of the gut microbiome, which is played an emerging risk and is now appreciated as plays a causation in the development of rheumatoid arthritis. But remember, rheumatoid arthritis is pathophysiology occur because of an interplay of risk factors that will include the risk, the environmental factors, and now one of the other key features noted as a risk factor is the postpartum period, and many patients rheumatoid arthritis in this period usually find after postpartum they actually develop polyarthritis or genocidal, which points to rheumatoid arthritis. The other risk factors will actually include the positive antibodies, which cause a risk factor for rheumatoid arthritis. So rheumatoid arthritis therefore is suspected in individuals with a family history of the disease, and those who present with multiple joint pain. Sometimes in the early phase of the illness, then there is no elevated inflammatory markers, but one on examination does not find joint swelling, and then we call this clinically suspected. But commonly then, as the disease advances, we get multiple swollen joints, and the commonly affected joints are the wrists, metaphalangeal joint, proximal metaphalangeal joint, the elbows, the shoulders, the knees, the ankles, and the metaphalangeal joints. And these individuals we usually will do antibody testing, and they usually have positive serology, the rheumatoid factor, we all know, and the And the other bit that will help us to confirm that somebody has rheumatoid arthritis or suspect somebody has rheumatoid arthritis is suggestive radiographic features. You might have a patient who has negative serology, but when you do X-rays, you find joint space narrowing, you find periticular osteopenia, or you find marginal erosions. This then will suggest rheumatoid arthritis. Sometimes also is lateral, and picking out tenosynovitis, picking out synovitis in the joint, and picking out erosions even before they occur in plain radiographs. MRI the same, picking out those features that I mentioned. And useful to differentiate, let's say, with spondyloarthritis, which will occur beyond the joint, and the example of psoriatic arthritis, which will occur in the ends of the regions around the joint rather than occurring on the joint itself. The other features that might lead to suspicion of arthritis is extraarticular features. We all know about rheumatoid nodules. Eye disease might also lead to suspicion of arthritis. Pulmonary involvement, and sometimes some patients have actually been diagnosed with rheumatoid arthritis based on joint biopsy when the patient presents with, let's say, one joint involvement, and then they have histology that is suggestive of rheumatoid arthritis, or a nodule that is biopsied and then it comes out as suggestive of rheumatoid arthritis. So what is the usual clinical presentation? So rheumatoid arthritis presentation is divided into two. We have patients who have early rheumatoid arthritis, usually less than 2 years of history. Progressively, we're taking the period lower than that. Not even use 1 year or very early, whereby you're looking at months. The whole aim, of course, is to identify these patients early. And Dr. Nakari will discuss why it's important to pick patients early, because that's what we call the window of opportunity. If you look at that theory, to suggest so early rheumatoid arthritis, you have these joint pains, usually multiple joint pain, multiple joint swelling. Rarely do you get less than 4 joint involvement or 1 joint involvement. You have early morning sickness, you have functional impairment, you have relative inflammatory markers, you have the serologies where possible. And then for established rheumatoid arthritis, it was occurred more than 2 years of history. Symptoms are similar to the ones above that I mentioned. You now have other joint involvement because what is arthritis for long, period you're developing deformities, you're also having functional impairment, you're having obvious radiographic evidence of damage, which include erosion, space narrowing. So this the period that we get. And just before I go to the next slide, on clinical presentation, there are several ways arthritis can present, whereby there's a traditional one which we know as a polyarthritis. We also have a polymyalgic presentation, whereby we present with the proximal joint, the shoulders and hip involvement as if they have polymyalgia. So that is one of the ways, and as I mentioned here, the arthritis and the rare presentations. In some patients actually have arthritis affecting one side of the body. That also can be one of the diseases. Those are typical presentations of rheumatoid arthritis. It's important to remember about the antibodies because many people tie this to rheumatoid arthritis. Remember that antibodies are not, they don't make a diagnosis of the disease. Rather play a part in the diagnosis. And these antibodies include rheumatoid factor. Rheumatoid factor is antibodies against the AFC fragment of the globulin gene. It's present in about 50% of early rheumatoid arthritis, 80% in patients who have had rheumatoid arthritis established. It's not specific for rheumatoid arthritis. Very many false positive. It's present in healthy individuals and also present in other conditions like liver cirrhosis, malignancy, HIV, and very many other medical conditions. CCP was discovered, and now we are the second generation of anti-CCPs, and they have high specificity for rheumatoid arthritis, and it's found in about more than 40% of patients who are rheumatoid factor negative. Anti-CCP is more than 80%. And this anti-CCP is a product of post-translational modification of arginine to citrulline, and these antigens that are circulated will include collagen, alpha-inolase, and fibrinogen. I mentioned them here because sometimes in somebody's reading, they will find something called anti-inflammatory antibodies and basically. So in terms of the diagnosis, how do we make a diagnosis of rheumatoid arthritis? Rheumatoid arthritis is clinical. Basically, there is nobody, it's a doctor or is a clinician who has to make the diagnosis. Everything else is supportive. Of course, it's based on the symptoms, based on the imaging, is based on presence of markers, is based on a patient fitting on this particular manifestation. So basically, it's a clinical diagnosis. And like I mentioned, you can have histology. But for purposes of enrolling patients into clinical studies, and also it has been found to be useful in the diagnosis, always not a diagnostic criteria. The European League Against Rheumatism, or the European League to Associate for Rheumatology, and the College of Rheumatology came up with a specific criteria. The criteria is as detailed, whereby if you have one joint involvement, the score is low, because then in this context, the chances of having arthritis is low. But like I mentioned, you can have arthritis. The key thing is this: if you have one patient with a persistent swollen joint, you must always send them for to an surgeon who you request them to do rheumatologist arthroscopy so that we can a biopsy. Then that's usually the way that you can make the diagnosis. But in terms of the classification criteria, then the score is 0. But the score keeps on increasing till 5 for patients with polyarthritis, especially if they have more than 10 joints involvement, especially involving the small joints. For positive serology gives you a high score, especially if you have a high positive score, which is usually more than 3 times the value of normal, which is score 3. And if you have durations which are prolonged more than 6 weeks, you get a score 1. The reason why the duration came is that most arthralgias less than 6 weeks of duration are usually because of viral illnesses. Then if you've elevated inflammatory markers, CRP or ESR, then you get a score 1. If one gets a score of 6 or more, then from this classification criteria, it makes that one has definite rheumatoid arthritis. This EULA criteria actually has very good performance in terms of classifying a patient to have rheumatoid arthritis. The other bit, like I mentioned, is through histology, but this is now what supports a clinical diagnosis. If a patient has one joint involvement or has a nodule, and you're now trying to confirm what it is, like a pulmonary nodule, and done a biopsy, when it comes out typical rheumatoid arthritis, and you say, oh, this patient has rheumatoid arthritis. Imaging, like I mentioned, the MRI features, the ultrasound features, and the radiograph features. The other important aspect is seronegative rheumatoid arthritis. In some patients, they have all the features of rheumatoid arthritis, even sometimes imaging features, but do not have positive antibodies. The rheumatoid factor test is negative, and the test is negative, but are still classified or diagnosed as seronegative arthritis, and as such, defeat within the treatment, for treatment, just like a patient who was positive arthritis. Now, what will mimic rheumatoid arthritis? So there are many patients who will actually present with polyarthritis. Not all polyarthritis is rheumatoid arthritis, but remember, patients with rheumatoid arthritis is the commonest inflammatory arthritis. So usually when you have polyarthritis, one of the things you must think about is arthritis. At the same time, now you have to ensure that you're not missing out connective tissue diseases, which include Sjogren's, lupus, scleroderma, the inflammatory muscle diseases, which may actually present with polyarthritis. The other bit that the other diseases that can actually cause polyarthritis, and especially in our setup, it's very important to remember is HIV. HIV has many ways to present, but it presents the joints, and the one of them is that it presents as what we call HIV arthritis, which is a polyarthritis. Hepatitis B, and we are grateful that the vaccine has reduced the incidence of this, but there are patients who are not vaccinated, and hepatitis B still presents as arthritis, especially in people who are like from northeastern province because of the maybe uptake of the vaccine or the cultural ways. So hepatitis B still remains an important virus to screen for in patients with arthritis and hepatitis C. The other bit, like patients who are from Garissa, Mandera, Mombasa is chikungunya, which also presents as polioarthritis and anemic arthritis. Of course, osteoarthritis, especially the inflammatory osteoarthritis, where you have features of joint swelling, although you have then radiographic features. Psoriatic arthritis can present as a polyarthritis. Sarcoid, though a rare disease, may have present with polyarthritis. Patients who have Takayasus present with the polyarthritis. Giant arthritis presents with a polymyalgia picture that polymyalgic rheumatoid arthritis. Polymyalgia rheumatica itself may mimic or can be a close differential for rheumatoid arthritis. Crystal arthritis like gout. Gout can actually cause a polyarthritis. And tophies on the elbows, which can be then confused as nodules. So one needs to take carefully to look out for other tophies. Go to the polyarthritis gout from rheumatoid arthritis. The other is the other crystal diseases, CPPD, calcium pyrophosphate disease. In patients who have rheumatoid arthritis, let's say early rheumatoid arthritis, and present with clinically suspected arthralgia, one of the differentials is fibromyalgia or compressive regional pain syndromes. Those are predominantly pain disorders. CRPS may actually present with joints with swelling and mimic and arthritis. So it's an important differential to remember. The other bit is a complete spectrum of disorders, which one needs to remember as a cause of pain. The other mimic here, that it's not a mimic per se, but it's a variant of rheumatoid arthritis, is called palindromic rheumatism. It's a form of arthritis whereby usually it's rheumatoid factor negative and CCP negative, and you get episodic, painful, swollen joint with intervals whereby there's no pain. It behaves like gout, so it's a differential for gout and arthritis. So what are the complications of rheumatoid arthritis? The reason why I put all this here is most of the patients, even doctors will ask, why must you treat patients with rheumatoid arthritis? And I list these complications, sorry that the slide is busy, but just to remind us that you can get nodules in the skin or various organs, even the brain, lungs. You may get carpal tunnel as part of neuropathy, peripheral neuropathy, vasculitis, vasculitic ulcers, digital gangrene, in rare cases, pulmonary, where you get pleural effusion, nodules. Severe complication of rheumatoid arthritis is the usual interstitial pneumonia. Hematological complications, commonly anemia, rarely Felty syndrome, neutropenia, and splenomegaly. Ocular complications are common, the episcleritis, which is a mild disease, scleritis, which is quite serious and can lead to visual loss, keratoconjunctivitis, sacca, uveitis, retinovasculitis. Oral complications will include sicca, dental caries, cardiovascular diseases, ischemic heart disease, very important, and leading cause of death in patients with rheumatoid arthritis. And it's an important thing to look out always for and screen for. One does the usual routine risk factor for cardiovascular disease like high blood pressure, diabetes. Remember that rheumatoid arthritis also increases the risk. In the scoring system for risk of cardiovascular disease, then you remember rheumatoid arthritis and usually multiply by a factor. The other bits, of course, you can get the pericarditis, osteoporosis, osteoporotic fractures, increased risk of infections. The risk of TB in patients who have rheumatoid arthritis is 2 times that in the general population. The risk of disability, functional decline is still a reality if a patient is not adequately treated. There's a slightly increased risk of malignancies, lymphomas, lung cancer, and it's one of the things that we need to keep an eye on. In patients who are not treated for rheumatoid arthritis, remember they have premature death, and it was shown in many studies that they die of 8 to 10 years earlier than their age mates. So these are just pictures as we take a small break. That demonstrates this is one of the patients who has established rheumatoid arthritis, and as you can see, the osteopenia, and you can see this significant erosions and almost destruction of the distal ulna and now the total subluxation at the wrist. The same patient who had significant involvement and damage to the knee of rheumatoid arthritis. These are pictures to show involvement. This is scleritis, and this is very severe scleritis. This one with the cursor that demonstrates scleromalacia. So this is the worst complication of rheumatoid arthritis and leads to blindness. These are also pictures to show rheumatoid nodules in the lungs. There are arrows to point to it. This is one of them, and then this is the histology for the nodule. And this is another complication of rheumatoid arthritis, where usual interstitial pneumonia, and you can see the degree of honeycombing and basically damaged as a result of rheumatoid. This is specific pneumonia where you have inflammation in the lungs, and this is actually reasonably amenable. And this was just to set up the stage for factors which you need to consider in treatment planning. So what are these factors that we look at? We look at, usually it's important to remember the comorbidities. Have HIV, hepatitis B, diabetes, malignancy, heart failure, liver disease, because this helps you in seeing the use. Current and recent severe infections, because then you usually avoid biologics because they can cause further immunosuppression. Sulfur allergy, basically to avoid chloroquine, sulfasalazine. Pregnancy and lactation is very key because most of the patients have rheumatoid arthritis at a young age. You do not want to give them a medication which at the same time is going to cause fetal malformation or affect the newborn child. Of course, the childbearing age also plays a role in terms of the drugs that you select. If a patient wants to conceive, then usually you'll avoid Brexit, you'll avoid fluoride, just as an example. Of course, cost of treatment plays a key role, and it's one of the things that affects how we treat patients in our facility here at Kenyatta, because the new treatments are though effective, but still remain prohibitively expensive, and therefore we are then forced to do combination therapy sometimes more than 2 or 3 agents, 3 or 4 agents, because of the cost of treatment affects their treatment planning. In a few patients, there have been foveal injections, and then that also affects the drugs that we use. What is the previous treatment history, and what was the response to treatment? Early versus established rheumatoid arthritis. And something to mention here is the other factors that you need to actually remember, which I mentioned later on, is the factors. The patient have good, the patient has poor prognostic factors. If there are poor prognostic factors, then you will need to usually use combination therapy, or you may need to use early, but I can speak about this. If you have a patient who has hypogammaglobulinemia, which is known, then you usually need to avoid drugs that include it. So this basically affects what sort of drugs that you use. This is an important question for many people who will ask. I thought to just preempt it here. I threw it in the middle of the other slide. What is the role of nutrition and exercise in rheumatoid arthritis? And there are many studies, and the red meat does not increase the risk of rheumatoid arthritis, but there are studies suggesting that high red meat intake, like if you take red meat, then there's increased risk. But if you take fish which is rich in omega, it's an oily fish, it's not to decrease the risk and also improves the disease control for rheumatoid arthritis. Eating nuts is thought to increase the disease activity, not prevent you from getting arthritis, but increase the disease activity. Vitamin D supplement, vitamin D, good vitamin D levels actually basically start to decrease the risk of arthritis. Being obese increases the risk of arthritis. In terms of exercise, what should one do? The important thing is that because of the high risk of cardiovascular disease, then patients though have this arthritis, they need to keep an active lifestyle and exercise if possible at least 30 minutes each day. At minimum, do brisk walking. But if somebody is more active and not in pain, the advice is avoid contact sports like rugby, football, but one may do yoga, one may do aerobics, swimming, jogging, provided it's a sport that does not lead to injury. We are in the COVID era, and it's important to mention COVID. Did patients with rheumatoid arthritis have a worse outcome in terms of COVID? Not really, except those who have been on severe immunosuppressive therapy, they also have fear. And in patients with rheumatoid arthritis vaccinated against COVID, very, very important, because there is this fear, and there is now evidence to show that they are slightly of getting COVID, and of course the COVID complications. And remember, we have mentioned about rheumatoid lungs. So if you have rheumatoid arthritis and you have pre-existing lung disease and you get COVID, it's already been shown that the outcome of patients with pre-existing lung disease have a poorer outcome. So it's very important to vaccinate patients with rheumatoid arthritis against COVID, and also for them to get the other vaccinations. The other bit is just to mention that post-COVID vaccine, there's reduction in antibodies, and therefore one needs to space in patients who have already. The other vaccines that patients should get is pneumococcal, influenza, HSV, and the other routine vaccination. One of the things to remember is the yellow fever vaccination. Please avoid patients who have suppression. Usually they are the ones you give a letter to advise the various countries that they accepted. So you have now a patient with rheumatoid arthritis. How do you follow them up? How do you know whether they're improving? One of the things that is confirmed in various trials, this is useful in daily clinical practice, is to do disease activity assessment. What we usually will use are what are called composite disease activities. So I will not go into them, but they're important to know that they are there. The DAS disease activity score, simplified activity index, clinical activity index, which basically the CDI does not require any blood test and is useful even for us where we sometimes we're not able to get blood tests. And there are other patient-reported outcome measures. These are all validated and they're useful for follow-up and ways to assess for functional impairment and disability. So it's always important to assess this activity, and that's what also helps you in confirming that the treatment that you put the patient on is effective. What is the natural clinical course of patients? So if a patient has never been treated for rheumatoid arthritis, they have come, what is expected? That in a small proportion of patients, about 5 to 20%, this was a publication in 1995, it will be self-limited. In about 5 to 20, they'll progress, but not without a lot of problems. But majority of the patients, 90%, will be progressive. And the progressive issue is that it leads to usually disability, joint destruction, and eventually to disability. And of course, we have mentioned the increasing cardiovascular risk factors, the vasculitis, and all the other complications. What are the prognostic markers for rheumatoid arthritis? The prognostic markers would be high. These are just some of them. If you have high rheumatoid factor titers, you have positive anti-CCP, you have early radiological changes, you have one is a smoker, the presence of a shared epitope, the genetic risk, which is the HLV, ERB5, the 5 amino acid sequence motif. If there's extra-articular involvement. So these are the negative prognostic markers. And this will actually affect your treatment. And this may suggest that you need to be a combination therapy or sometimes early initiation to biologic or what we call small molecules, which I will speak about. And thank you very much. And now it's my opportunity to hand over to my colleague. Welcome, Dr. Kitale. She's a colleague of mine. We work together here at the Rheumatology Clinic in Kenyatta. And she's a specialist in rheumatology. And also work she's done a training and recently came from South Africa. And we are very glad to have her with us. She also is the secretary for our Rheumatology Association.
Okay, thanks a lot, Dr. Tao, for that introduction. Just as we are, perhaps, as you are sharing and I share my screen, there are 2 questions that have come up in the chat. Maybe you can be handling them as I share my screen. One is about, is there any correlation between cold weather and arthralgia? And the second one It's really about how long does it take to get complications, whether you're treated or not. Mentioning that in clinical diagnosis, there's over-the-counter medication, delayed diagnosis. So as you're handling that, I'll be sharing my screen.
Thank you, Dr. Agitari. Be happy to respond to the questions. Thank you, Jane, for the question. So, yes, the problem is the over-the-counter medications. Usually we allow me to use the word light the patient, that they're actually getting better, and therefore they delay to seek treatment. So yes, so it causes a delay. And remember, the patients who present early do better in the long run. Now, the treatment for rheumatoid arthritis is patient-based because different patients respond differently. And therefore, the duration of treatment will vary with how the patient is responding to the drugs. At the moment, we don't have any evidence that will tell you that this patient will be on medication for 4 years, will be on medication for 2 years, but the patient will require to be on follow-up treatment. And Dr. Nakari might mention about treatment tapering or treatment breaks and the things to follow. But usually the patient, it's a case by case, and the patient close follow-up and to continue with the many patients report that during cold weather, thank you, Kevin, for the question, they have joint pains. But in terms of, there have been studies that have been done in the coldest areas, the areas where they get minus 40 degrees during the winter, and they were not able to correlate actually weather and disease activity. But patients actually report that they feel worse and they feel more pain during the cold. But in terms of disease activity, there's no evidence to show that it actually causes higher or worse disease activity. Thank you, Dr. Nakari. Please.
Okay, so thanks to Dr. Etal for that first part of the session. For those who have just added questions, we'll look at them after this final part. So mine is just to discuss treatment options and long-term outcomes. So I'll mention a few aspects, and if there are questions and discussion points, we can continue. So a lot has already been said about rheumatoid arthritis, including the preparation for treatment. So the main thing that one needs to bear in mind is that this is a team cooperation affair. There are non-pharmacologic and pharmacologic approaches, both of which actually have, I would say, equal standing. And one has to also consider the issue of comorbidities. So your multidisciplinary team at the center usually is a rheumatologist, but in resource-limited settings such as our own, and rheumatologists actually are not that common, physicians often take our place outside the urban areas where we're not available. Other healthcare workers also may have to manage rheumatoid arthritis, or at least identify it and refer the patient. The other members of the team, not in any order of preference, but remember that there's a lot of counseling and mental health support that is required. So you need a social worker, you need therapists, both physiotherapists and occupational therapists, to manage functional disability. Issues of nutrition have already been discussed, so that is a member of the team. Rheumatology nurses are actually a key member of any proper rheumatology unit. You need a pharmacist, and not mentioned here is an orthopedic surgeon. That was an omission, but the orthopedic surgeons do come in management of these patients, and podiatrists for foot problems. So the non-pharmacologic things that you need to consider, we've already spoken about the mental health aspects, where many of our patients with rheumatologic problems are at a higher risk of depression. So one needs to look into that. And because of the functional disability, they may struggle at work, as you can see there, and they may struggle even in the home, in marriages, in childcare, and they need support for all this. They need to be counseled, and they need to be educated on how to self-manage. They also need to be directed to support groups, and we need to help them to access assistive devices and appropriate shoe wear or other devices, things like orthoses and insoles to help with their daily activity, managing the activities of daily living. Reproductive health counseling has been mentioned. Majority of the patients with rheumatoid arthritis are female. Therefore, the issue of current pregnancies, future plans for pregnancies, so that one can manage the medication around that. The vaccination plan is also something that you need to do. Where possible, patients should be vaccinated before one begins proper DMARDs, particularly the biologic DMARDs. Currently, Kenya is, there are a few specialists and subspecialists who have been brought together to plan for vaccination guidelines in Kenya for the different chronic illnesses, from rheumatology to renal and so on. We hope that that guideline will assist all healthcare providers to know the plan. But in general, you want to make sure that your patient has been vaccinated against hepatitis B, pneumococcal vaccination, accesses a flu vaccine, zoster vaccination, if possible, but I think it's quite expensive at the moment. And with the current problems, COVID vaccination should also be looked into. Of course, live vaccination is not recommended for patients who are on immunosuppressive therapy, and that has already been mentioned. So when you come to your pharmacologic treatment, we are shifting away from the one size fits all to more of stratification and individualization of treatment. We are looking at phenotypes, whereby in rheumatoid arthritis, issues about seropositivity and disease activity at presentation help to stratify patients from those who are more likely to get severe disease and therefore need more aggressive treatment. Here in this table, you can see there's a column talking about predictors of disease persistence. These are factors that have been collected in what we call early arthritis clinics. In other countries, which at the moment are more developed than ours, they run what we call early arthritis clinics, where primary healthcare workers or any other healthcare worker refers any patient who is a suspect for possible arthritis or possible rheumatoid arthritis. They're referred early to those centers where they're evaluated by rheumatologists, and then those who need to be followed up are followed up. Those for whom it is not thought to be a problem can be referred back. So the chances of a patient developing proper rheumatoid arthritis when they're still under suspicion, those factors are listed there, which include again seropositivity, cigarette smoking, gender, and other factors about the symptoms. But for those patients who have these factors, again, including seropositivity and disability scores and high joint counts and other biomarker issues where you can see this shared epitope, part of those things that were mentioned by Dr. Tao at the beginning, the HLA epitopes, a number of them predict patients will get more severe disease, and this can be used to understand who needs more aggressive treatment. A lot of people are doing research on other biomarkers, and I'm sure as we go forward in the future, we'll have an idea of who to treat specifically in what way. Under pharmacologic, I've decided to include the assessment of disease activity, because when you're giving your treatment, you need to know what your target is, and you need to objectively measure it and know what you're moving towards. For this, these various disease activity measures have been provided, and for the clinical, the simplest is the CDAI, which is easily available on any device, which includes the number of tender joints, the swollen joints, how the patient assesses themselves, and how the physician assesses the patient. You can then target what we call remission, because they have different scores. So you target at least low disease activity, at best remission. At the same time, one should periodically assess the disability of these patients using the HAQ score, of which there are various types, which are also accessible on the internet and other devices. So this is a simple flow chart. This is from the EULA guidelines for rheumatoid arthritis, but note that the Americans also have their own guidelines, but this flow chart I thought was easy to follow. It just reminds us that, first of all, the anchor drug for treating rheumatoid arthritis is methotrexate, and you only use other medications without methotrexate if there's a specific reason why not. When you start methotrexate, You can combine with glucocorticoids, but remember that the dose of glucocorticoids should be most of the time low, which is maximum 10 milligrams per day. In basic rheumatoid arthritis, when you don't have some specific systemic involvement, it is unusual for you to require moderate or high dose or even pulse glucocorticoids. You can combine these medications, and we'll see in the next slide that it is possible to combine them if the patient does not initially respond to methotrexate. You'll notice that hydroxychloroquine has not been included here. A lot of these guidelines do not give hydroxychloroquine a very prominent place as far as strong demands are concerned, but we often combine methotrexate with hydroxychloroquine because we think that hydroxychloroquine somehow augments the activity or helps methotrexate with its action. With these other medications, leflunomide or sulfasalazine, maybe not as much. So you want to see whether your patient improves either 3 months or 6 months, and you use those disease activity measures that we mentioned. And if they're not improving, you combine, in which case you can combine 2, even 3 of those what we call conventional synthetic medications. These are the oral medications that we all commonly know. They are called conventional synthetic or CSDMAs. So for the patient who has these poor prognostic factors as mentioned here, where they are seropositive, they have high disease activity, or they're not responding to these DMARDs, then you want to go to a biologic DMARD. And therefore, where the resources are available, it is possible to almost immediately go to a biologic DMARD if the patient has poor prognostic factors. Here in our setup, we prefer to at least give conventional synthetic DMARDs a chance, and that is mainly for financial reasons. So then you can go to your DMARD, or you can go to what we are calling the JAK inhibitors, and then you continue with that cycle. And if they're not improving, because there are various DMARDs and JAK inhibitors, you can rotate between them. And then you decide from there. So your target is to get the patient into sustained remission. These are some of the medications that are used in rheumatoid arthritis treatment. These are conventional synthetic DMARDs we've mentioned here, methotrexate being the most common, often started at 15 milligrams weekly. Main side effects, nausea, vomiting, but be aware of the liver functions being affected. Issues surrounding risks of ILD. I think, of course, this can be discussed at other levels or higher levels, but we don't think that methotrexate at the moment is a great contributor to interstitial lung disease. Hydroxychloroquine, as we know it, used usually once a day, sometimes twice, and probably eye assessments should be done at baseline or from 5 years onwards if the patient has been on this for a long time because of those risks of retinopathy. But there are other side effects that we often ignore, including GIT intolerance. Salazopyrin should be built up to a dose of 1 to 3 grams per day. It also has its own side effects and maybe not thought to be as effective or as strong a DMARD as methotrexate, but it still does work and is often used in pregnancy because the other drugs, sulfasalazine and hydroxychloroquine, are the main drugs used in pregnancy. Leflunomide and methotrexate have a lot in common. Moving on to some of the biologic DMARDs that we use, TNF inhibitors, some examples are given there, rituximab, which is also given there some details. Remember to vaccinate before using any of these biologic DMARDs. We also use tocilizumab. I think we got a lot of experience using tocilizumab during COVID for those who are treating COVID, but it is used in rheumatoid arthritis. And more recently, some of the JAK inhibitors, an example is tofacitinib, but there are now quite a number of molecules coming up. So for all of them, you want to make sure that you're aware of the side effects. Some of them need infusion, some of them need subcutaneous injections for which the patient has to be trained. And so for infusion, remember to consult experts before using them. Be vigilant for TB, particularly with the TNFs, and be vigilant for other side effects involving the liver and cholesterol and other signals that have been mentioned for others. Glucocorticoids. I think we are all familiar with glucocorticoids. Most common is prednisone used here. Multiple side effects. It is used as bridging therapy, but we encourage that within 3 to 6 months, you should have tapered down your glucocorticoids to minimum level and if possible, stopped your medication. As I said before, usually doses between 5 and 10 milligrams per day are sufficient for most of the time, and you need to stop as soon as possible because of its various side effects, and only use it judiciously. One also
Are you able to hear the?
Doctor, I think she's dropped off.
Oh, she's dropped off. Okay. Better use my computer.
just dropped off.
Okay. Apologies for that. Just give us 1 second.
Okay. Okay, I hope you can all hear me now. We'll just continue from where we are right now. So I think I was at, let me just start from comorbidities. If there's any issue, you can let me know. I'll just continue speaking as we figure out other things. If there's any issue, just put it in the chat, please. So we were talking about comorbidities. We talked about increased cardiovascular risk for this group, and the fact that they are at an increased risk for myocardial infarction, they have accelerated atherosclerosis. Huh? Hello? Okay, so I'll just continue. Medication side effects, glucocorticoids. I mentioned NSAIDs and GIT bleeding. I mentioned glucocorticoids, osteoporosis, but also because of the rheumatoid arthritis itself, malignancy. They are at an increased risk of hematologic malignancies, that is lymphoproliferative and other melanoma and other malignancies. And then for infection, they're at an increased risk of infection. Rheumatoid arthritis is a risk for TB, and some of the medications also increase the risk of TB, but there are also other infections, including pneumonia, and increased hospitalization rates for our patients. So just 1 or 2 things about the natural history and the outcomes of rheumatoid arthritis. So rheumatoid arthritis is a progressive disease, as has been mentioned, and for some people it can be stable or slowly progressive. For some people it can be rapidly progressive, and other people it's intermittent. But by and large, most of the people at some point will have some functional disability, and most of the problems will have occurred within the first 2 years of the disease. Hence the importance of early treatment so that one can reduce the level of joint damage at baseline and therefore reduce the level of disability in the long run. There are various people who have done cohort studies over time, some in the early 60s, some more recently between the 90s and the 2000s, of following up patients for 10 to 20 years to see how things continue for rheumatoid arthritis. And it has been found as soon as you start your, of course, disease activity goes down and functional disability, functional ability improves. But with time, as the years go by, from 7 to 10 years, the reality is that functional disability will increase. It is just the level which differs, that with more medication and more recently, that level of functional disability is lower than it was in previous years, which means that probably our medications do make some difference. Is there a difference in mortality? The rheumatoid arthritis patients, yes, have a higher risk of premature death, and probably this has not yet normalized as much as we'd like it to, because one wants, of course, the survival of rheumatoid arthritis patients to be almost the same as the general population. And though we are approaching there, we are not yet quite there. We will see the causes of death in the next slide. We've already talked about that there's an increased incidence of infections and cardiovascular disease and lymphomas, and that their life expectancy is lower than the general population. So the causes of death for these patients, most of it is cardiovascular risks. And what does this mean? It means that when you have a patient with rheumatoid arthritis, don't focus on the joints only. Make sure that you assess the cardiovascular risk factors, manage hypertension, have a weight loss and exercise program, and manage dyslipidemia, and manage all those other issues so that you can reduce the factors that contribute to mortality. Remember, infection, especially pneumonia, but there are others, contributes to cause of death. The cancers we've talked about. You can have renal disease from amyloidosis, though it is much less common nowadays. The GIT bleeding is an issue from the NSAIDs, and therefore one has to manage how often you give the NSAIDs. And the complications of rheumatoid arthritis itself, including for those who have axial problems, the myelopathies that may occur. Interstitial lung disease is also a problem in rheumatoid arthritis. This can also contribute. So this is just a graph showing that over time, with this cohort that was looked at, the reasons for hospitalization, over time, infection as a reason has increased. That means we also need to keep an eye on it. Though the cardiovascular problems, cerebrovascular disease, heart failure, myocardial infarction together constitute a big proportion of the reasons why they die. So I think I was also to mention something about, as you've treated these patients over time and you've probably reached remission, can you consider stopping medication, as many patients might come and want to stop medication? Issues of tapering have been discussed, have been tried, and tapering medication is an approach that one can take in somebody who has been in remission for a reasonable amount of time, say 6 months. And how to taper? You have to taper off glucocorticoids first, and then look at the other medications. If these are the biologics, you need to reduce maybe the dose or the time when you give the biologics and go slowly. Issues about stopping medication, this has been tried, and there are patients who can remain in remission for some time, but in the long run, I think most patients will reflare, and that reflare can be even more difficult to manage than the initial disease itself. So one really needs to look into this to be careful about the issue of tapering. And so for me, my closing remarks for today is that when it comes to rheumatoid arthritis, it's clear that the advantages to treating early, and one should then aim to identify and refer these patients early. So that brings me to the end of my aspect of the talk, and we're just going to look into the charts and the Q&As to see whether there are any other questions that had not been answered. Sorry about, I can see people had mentioned about the sound being lost. Sorry about that, I hope we are back. And then for the Q&A, let's see if there's any other extra question. So the question here is, I know taking folic acid helps replenish the folate your body loses because of methotrexate. So for how long do you give it? And the answer here is that as long as you're taking methotrexate, you should supplement folic acid. Once a week actually is acceptable, but here in Kenya, I believe we usually use it every day, which there's really no harm. But as long as you're taking the methotrexate, you need to take the folic acid along with it, because it's not so much about losses, it is about the mechanism of action of methotrexate and how it affects folic acid metabolism in the body. Let's see if there's anything else in the other chat. Okay. This other one here. Is there a role for intra-articular steroids? Okay, thank you for that question. Yes, indeed, there's a role for intra-articular steroids to manage individual joints that are swollen. So that is part of the treatment. And in fact, sometimes instead of increasing medication, if there's one troublesome joint, one can purely use intra-articular steroids to manage that. Okay. We'll see if there's any other question. Okay, so I think then there don't seem to be any other questions. So for now, we will want to bring this session to a close. Dr. Tao, any issues that you want to raise?
No, thank you very much all for joining us, and we would like to invite you on the 12th of October, which I'll be having another webinar, World Arthritis Day. We hope we can give you adequate notice, and we shall be talking on exciting topics on management of various types of arthritis. We appreciate your coming and being with us. Have a great afternoon. Thank you very much.
Okay, thank you to everyone, and we wish you all a good day.
Hi.